Hi, my name is Ashley Mila, and today I'll be explaining the external concepts on setup for ventral incisional hernia repair with the extended totally extraperitoneal approach, or ETEP. Right now, you can see us feeling the rectus sheath and its borders, including the semilunar line. We also make sure that the break point in the bed is lined up with the ASIS in order to maximize the abdominal wall stretch. Here you see us breaking the bed, maximizing the space between the ASIS and the inferior rib border. You can see my fingers separate as we break the bed. Breaking the bed maximizes the space between the ASIS and the inferior rib border to give us at least 16 centimeters for the placement of 3 robotic trocars. We do use IABAN to protect the field from movement during the robotic procedure, and we use monopolar and bipolar cautery cords, as well as a laparoscopic setup and a robotic setup, although you don't need to do this with the DV5 as it's built in. We do put everything on the left side of the patient's bed because as we roll the robot into the right side, the assistant will be working mostly on the left side of the bed. Here you see us reconfirming the semilunar line at the lateral aspect of the rectus muscle. This is our target, just 2 finger breadths inferior from the rib border. Here you see us again evaluating our ASIS. We do attach insufflation to our KFOS OptiView trocar. The goal here is to OptiView into the rector rectus space at the lateral most aspect of the rectus muscle. And so we start just medial to our semilunar line and aim straight down toward the retrorectus space. First, you'll see us go through skin, subcutaneous fat. You'll see a predominant scarpous fascial layer. We do have our insufflation active, and then you see us pop into the recto-rectus space right here as the tip shows a flash of white and yellow. Once you see that flash of white and yellow under the muscle, you can rock the camera up and down, rectus splitting, not rectus shearing, and then work the tip of the OptiView down and medially toward the midline, skiving under the rectus muscle in the retrorectus plane. Once you've gotten this, you Seldinger the rest of the trocar in over the camera, and we use both blunt, visualize, and blind dissection to open up the retrorectus space. You can see here that Dr. Bloom is using his left hand to feel the distal aspect of the camera as he works the camera bluntly and blindly medially toward the midline and then sweeps up and down in the retrorectus space to open the space. Once you have a good enough space there, you can advance your trocar further and insufflate the retrorectus space well. Once you have created your entire retrorectus space, you can now turn toward placement of additional 2 trocars. We first start at the trocar, just a finger breadth above the ASIS. We use our local needle as a finder needle to visualize exactly where we're coming in the retrorectus space. Here you can see that we easily visualize the finder needle in the retrorectus space, and that guides the placement of our trocar. We use an empty trocar to mark exactly where we're going to make our incision, and so that we don't create an incision that's too big and have insufflation loss during the procedure. We try to follow the exact trajectory of our previous needle, and here you can see that using that trajectory, we're able to pop just into the retrorectus space at the lateralmost aspect of the rectus muscle, providing the maximum working space for the robotic arms. We can also use this trocar to bluntly open any residual soft tissue in the retrorectus space. Next, we take our ruler and we measure out between the superiormost and inferiormost trocars, placing a mark to allow us to visualize exactly the middle of these 2 working ports. You ideally have at least 8 centimeters between them. We again use our finder needle to find the lateralmost aspect of our retrorectus space. Use that as a guide to place our trocar. Again, we use an empty trocar to visualize exactly how big our incision should be, and it almost tends to glow in the dark when you're looking at it with the laparoscopic camera through the outside. We make our incision exactly the length of what our incision needs to be, and are able to use the trajectory of our needle to get just into the retrorectus space at the lateralmost aspect of the rectus. Now that we have all three working ports, we then put the camera in the inferiormost port and exchange the superior 5mm port for the 8mm robotic working port. This is done just with direct visualization. Now we truly have all three robotic working ports in place and ready for docking. Because we start our dissection on the superiormost aspect of the retrorectus space, we place our smoke evacuation on the superiormost port and our gas insufflation on our inferiormost port, and put away the laparoscopic equipment in order to dock the robot. Here, we do not do any targeting, so it's especially important that you as the bedside assistant know exactly what the limitations are to the Da Vinci robot. Here I am moving our first arm out laterally to allow for maximum space and movement of arm 2, which will be our left working arm. We use a grab and pull method to get the robot docked. We grab the arm and pull it down to where the working would be, and then we bring the trocar to the robot. There are a few things you have to take note here, mostly at the base of the robot arm and at the elbow of the robot arm. At the base, you need to make sure that the red extremis line is not exposed. If that's the case, grab a clutch button and pull the robot down. Then you want to make sure that the elbows are maximally spaced, because we are working at the extreme superiors and inferiors of the abdomen, and if the elbows are too close, you will have clashing. We also make sure that the camera cord is looped around, because if it is left dangling, it will contaminate. We also make sure that the right trocar is not docked and that is left out so that the camera can move at full capacity to visualize the left trocar. So now I move the camera all the way to the right. As you can see, if I was docked, I would be blocked, and I'm able to advance the left grasper to the midline and then up toward the xiphoid. You notice here that as I did this, my elbows clashed. If elbows are clashing now, they're going to clash later, so it's best to use our elbow range and move it out of the way. Here you can see I'm able to complete placing both the camera and the left working arm in the superior aspect of the retrorectus space, and now I'm free to dock my right working arm with a hook. Once I get the hook in for any robotic instrument, while it is registering that instrument, that's the time that you have to grab your cord and plug it in. Now I'm able to push this into the retrorectus space. Now that all three trocars are in and ready, I burp them all up to make sure maximal efficiency. Once we're done with our procedure, we pull the robot away, and it's now time to deploy our mesh. We now bring a 30 by 30 soft mesh into the field and get it ready for cutting. Before undocking, we have already measured the retrorectus space, specifically after closing the posterior rectus sheath. We use a triangular folding method to cut the mesh evenly on both sides, folding in half and then in half again into a triangle. We then measure half of the distance of the retrorectus space. We then cut off any excess mesh. This creates a beautiful shape that perfectly fits the retrorectus space, and we roll it, keeping in mind that this will have to go through an 8mm robotic port. After grasping the mesh, we do dip it in saline to help facilitate its movement through the inferior port. We use our camera to visualize the mesh going into the retrorectus space. There are a few keys to this as well. One, the rolled mesh cannot have any kinks in it. So once you get it into the belly, you line it up in the midline to ensure that there's no folds in the long roll. If there's any folds in the long roll, it makes it almost impossible to unroll. So we make sure that this is straight in the craniocaudal direction. We use our left instrument to pin the roll to the lateral retrorectus space, and we use our other instrument to unfurl it towards ourselves. If you're having trouble unfurling the mesh at this stage, it's definitely because your log is kinked somewhere, so keep that in mind. Once the mesh is fully deployed in the retrorectus sheath, we do not secure it in place for the robotic approach, although we do secure it with VistaSeal in the open approach. We then turn our attention to placing a 19 French Blake drain. We do this by placing the external part in through the medial port, grasping it with a laparoscopic grasper, and pulling it out the inferior port, where we secure it into place with a nylon or silk suture. Then all that's left to do is to secure and close the skin of the superior and middle port sites, and you have completed the procedure.